Okay, I think we can start the conference, right? So welcome everyone to the third Evidence-Based Research Conference. Our theme is Seeing Further, the Past, the Present, and the Future of Evidence-Based Research. The conference is in webinar mode, but the Q&A session goes live. So we have a very interesting program ahead of us, and I sincerely hope you will join us in the discussions after each of the presentations. You do that by using the Q&A on the bottom of your Zoom screen. We have 10 stellar keynotes, 12 oral presentations, and 6 lightning talks. We are again having an online conference because the pandemic situation was not promising for an in-person conference at the time the conference was planned. Speaking of planning and organizing the conference, allow me please to thank members of the scientific committee for great ideas and all the support they provided. So huge thanks to Caroline Blaine, Klara Brunhuber, Karen Robinson, Malgorzata Bala, Raluca Špetku, Mihaela Kostikova, Jana Babiakova. Special thanks to Tale Jakobsen for the technical support, and of course to Hans Lund for making all this happen. Hans?
Thank you, Tina, and very welcome to all of you to our third evidence-based conference. Actually, this and the 2 first conferences was supported with from the Cost Association. But of course, anything good have always a timeline. So this cost action will, even though it had been such a great success in building a network, it will end by 16th of April in 23. So then we will move over to a more organized, more international network. We called it Evidence-Based Research Network, or EBR Network for short. We will renew that one, and so we have an official organization. And I would just like all of you to know that tonight at 9 p.m. Central European Summertime, we will have the first formal General Assembly that will also be online, and more than 30 have already signed up to this meeting. So if you are interested in joining, please let me know in the Q&A, and I will mail you the link for that. So I will also mention that you could follow @EVBRES on Twitter and or subscribe to the newsletter, our EVBRES newsletter, and I will put in the chat the email for Caroline Blaine when it comes to this newsletter. So if you would like to know about what's going on, please use that one. So Tina and I, we wish you all a very good conference, and thank you for joining.
Well, thank you so much, Hans, and please allow me to add my warmest welcome to you all. My name is Klara Brunhuber, and I'm based in London, UK. I'm your chair for this morning. My background is in medicine and health informatics, but I've worked in medical publishing for the last 3 decades, most recently leading a guideline project at Elsevier. When I sat down next to a me then unknown Danish researcher at a conference dinner on a balmy night in Sicily 9 years ago, I couldn't have dreamt that it would be the start of a great friendship, collaboration, and incredible journey that would lead me to become a founding member of the EBR network and vice chair of its Cost Action EVBRES, and now to be here with you today. A huge thank you for all this to you, Hans, who is also, by the way, my co-chair for this session. Would you like to add a few words about your background, Hans, for all our participants?
Thank you, Clara, and thank you. It was really a pleasure to have this very nice talk with you in this fantastic environment in Sicily back in 2013, actually almost 10 years ago. You know, I was originally educated as a physiotherapist in 1982, so I have a 40 years anniversary now. But my interest in research ended up in interest in, you know, evidence-based practice, systematic review, and that ended up with realizing that systematic review and other systematic approaches to the use of earlier research could be very helpful when you are preparing new research. And thanks to Karen Robinson, who will join us later today, it's very early in the morning in US now, we actually got a lot of good people, you, Clara, and a lot of other good people. Paul was also a part of the meeting. So we had a very nice start in 2014, and I'm so happy that we can continue this work. Yes, thank you very much, Clara.
Thank you. Well, we definitely have a wonderful program for you all today and tomorrow. And in this first session, we will hear 2 keynote presentations, both pre-recorded, so that hopefully all the usual technical glitches will avoid us. And this will be followed, as Tina was saying, by a live Q&A session with both our speakers. So please don't forget to send in your questions and comments as they arise via the chat box or the QA button. And now let's hear from our first keynote speaker, Professor Paul Glasziou, Professor of Evidence-Based Medicine at Australia's Bond University and Director of its Institute for Evidence-Based Healthcare. The first time I had the pleasure to meet Paul was back in 2003, during one of his visits to the BMJ offices during his first year as Director of the Centre for Evidence-Based Medicine in Oxford. And I still vividly remember our chat about our shared experience of moving countries with a family and how best to capture clinical questions as they arise during busy GP consultations for later answering, something that was very close to his heart as practicing family physician. I was so delighted when our paths crossed again 11 years later, as Hans mentioned, at the memorable launch of the Evidence-Based Research Network in 2014, when he joined us digitally, just like today. Paul's key interests include identifying and removing the barriers to using high-quality research in everyday clinical practice, investigating research waste, overdiagnosis and overtreatment, and promoting uptake of evidence for non-drug interventions and better prioritization, design, conduct, regulation, management, and reporting of health research. More recently, he was one of the founding members of ICESA, the International Collaboration for the Automation of Systematic Reviews. Today, Paul will talk to us about the founders' and researchers' role for making evidence-based research possible, easier, and the norm.
So, good morning from down under, and thank you very much to the organisers for asking me to speak about making evidence-based research possible, easier, and the norm, what funders and researchers and others can do about this. And I'm going to begin by talking about the nature of the problem briefly, and then talk about the types of things that have been done and what else we might do to try and work on this problem. So a bit of history first of all. We could go back a long way, but I'll just take this article of Doug Altman's The Scandal of Poor Medical Research in 1994 as a starting point, where he said huge sums of money are spent annually on research that is seriously flawed through the use of inappropriate designs, unrepresentative samples, small samples, incorrect methods of analysis, and faulty interpretation. And it had long been a frustration with Doug that these sorts of problems arose in research, particularly simple fixes that could be done that would salvage the huge waste that occurred in a whole project being done and then, for example, a faulty analysis or incorrect reporting. In 1994, though, he didn't document how big those huge sums were, and Ian Chalmers and myself in 2009 tried to estimate this in an article we wrote in The Lancet of about an 85% of research being avoidably wasted. Of course, there's inevitable dead ends, etc. in any research that we do, but this was the avoidable waste in research. And that includes several stages, including what the Evidence-Based Research Network is particularly interested in, which is at that design stage of research. the sorts of problems that we documented in 2009 have been documented in preclinical work as well. For example, Begley and Ellis tried to reproduce the findings of 53 top-tiered papers in Science, Cell and Nature, and could only reproduce the results in 6 of those. And that was done for commercial reasons because Glenn Begley was working at Amgen and wanted to make sure that before they pursued a line of research that the research was at least reproducible. And then in 2014 we had the 5-part Lancet series on adding value and avoiding waste. And followed that up with a conference, the Reward Equator Conference in Edinburgh, where Doug Altman had noted in his keynote about the slow progress in improving waste. He said, "It is my pleasure to be here and to make you feel quite sad about how bad things are, and then my colleagues will, I hope, come forward with great ideas about how we can make things better." So I'm going to pursue that theme of Doug Altman's of talking a little bit about making you sad first of all, but also hopefully end with some ideas that may make things better and how they are actually moving forward. So you obviously know that evidence-based research is defined as the use of prior research in a systematic and transparent way to inform a new study so that it is answering questions that matter in a valid, efficient and accessible manner. And that was, of course, documented, that problems were documented in the 2014 Lancet series, and we'd mentioned them in the 2009 paper. So I was just having a look at what rates of use of systematic reviews to justify new trials we find in the literature at the moment. And this is 4 different estimates ranging from 20% to 54% being justified. They all use slightly different methods, so I wouldn't read anything into the timeline here. Just take these as 4 separate estimates of the range across these different areas of anesthesiology, ophthalmology, major general medical journals and orthopedic trials. But it's not always clear whether the systematic review is being used to justify the new trial or being used to cite for other purposes. But it gives us a sense that things are not well, at least the glass is less than half full probably. So that means that for the consort statement where it says reference to a systematic review of previous similar trials should be given in order to justify and also build on the methods, and I'll come back to the methods, that we're not doing particularly well in that regard. And I'm going to talk about the implications of that in one specific example, and this is for calcium channel blockers in acute stroke, where in 2001 the Venus trial published finding no effects of nimodipine, which is one calcium channel blocker. And they also did a Cochrane systematic review published in the same year of all of the trials they could find of calcium channel blockers for acute stroke, and again found no effect. That's the forest plot on the left here, and you can see the diamond of the overall effect is actually slightly on the placebo being better side. So that made them ask, well, was this based on good animal research? Why were all these 28 trials done in so many participants? And going back to the animal studies, they found 20, and amongst those they didn't show convincing evidence to substantiate the decision to perform trials with nimodipine in large numbers of patients. So this is all the wrong way round. We should have been accumulating the evidence in the animal studies and then doing the first studies in man and accumulating the evidence in systematic reviews, and that's where evidence-based research should be moving to. And this was work done by Janneke Horn, who published all 3 of these articles, the trial and the 2 reviews. And so it all suggests a lot of avoidably wasted research effort with no progress in care as a result of this. So what can we do about this? Well, we could put up a sign in every laboratory that said, "Thank you for not doing research that has already been done." That would be very important. We might also put next to it a sign that says, "The clinical librarian is in this direction. Please go and consult them before you do your new research." We should also think about what the infrastructure and tools might be that might help those researchers in those laboratories do that in the first place, because people don't do it because of the effort involved in it in the first place. So I want to go back to another example of the rate at which methodological innovations are taken up, and just look at the 40 years that it took for the IMRAD, the Introduction, Methods, Results and Discussion Structure in Journals, to be taken up. This was first mooted in the 1930s, and by 1980 you can see that at least for these 4 big medical journals it had been completely implemented. This is an interesting 50-year survey published in the Journal of the British Library Association a few years ago. So there's this long gap between an innovation in what we should be doing to better structure reports and it actually being implemented. So how might we do something about it? One way is to think of this as a diffusion of innovations. So Everett Rogers, in agricultural research actually, looked at this in the 1950s. He was interested in the uptake of hybrid corn. And he classified people as being the innovators, the early adopters, early majority, late majority, and the laggards. And that you may need to do different things for these different groups. Approach them in different ways. And Brian Nosek has laid this out very nicely in a figure that he's got on the Open Science Framework, where he talks about these stages of changing a research culture. First of all, making it possible, then making it easy, making it normative, making it rewarding, and making it required, which sort of correspond to these groups that that Everett Rogers had described. For the innovators, you just need to make it possible. For the early adopters, you make it easy. For the early majority, make it normative. Late majority, make it rewarding. And the laggards, make it required or mandatory. So the question is, how might we speed these things up? And we need to think then about how we can make all the things in this pyramid go forward, make it possible, make it easy, make it normative, etc. In order to speed up and compress that 40-year or so timeline. So in a way, that's already been done. I want to take you back to 1836, when the first National Library of Medicine in the US was set up, and just to collect things together in one place that made it even feasible. You'd have to do a lot of work, but you could possibly have done a systematic review then. But imagine with the amount of literature trying to do that on Index Medicus in the, say, the late 1950s or 1960s, and having to go by hand through these volumes. Medline and PubMed was just to make this easier. So we've been doing this for searching. We've actually made it possible and then made it easier. And now it's becoming normative as well, but only because those things existed in the first place. You couldn't mandate that people would always do a systematic review if we still only had Index Medicus. So what I want to do is take that idea of we've done this for some components of searching by making it feasible and easier, but expand that to the whole idea of doing a systematic review. So this was the principle behind the international collaboration of the automation of systematic reviews, that we wanted to make it easier for doing reviews of new research of previous research before you do new research, or just to answer clinical questions. There's lots of purposes for doing a systematic review. And that has had yearly meetings, and I'll thank Hans Lund for hosting the 2019 meeting in Bergen, but we've had multiple meetings of that group and making gradual progress with these. Important was to set out the so-called Vienna principles from the very first meeting, which said that a systematic review production involved multiple tasks, first of all, and we have to think about all of the tasks, not just the title and abstract screening or data extraction, and that automation may assist with all of those tasks, and that each of them can be continuously improved. So we make one step forward, but we need to go better and better and better, particularly focusing on things that are the bottlenecks. But once you solve one bottleneck, you actually move on to a new bottleneck, and you always want to be working to improve whatever the current bottleneck is. and that with all of this process that we need to adhere to high standards. We're not talking about the rapid review process or shortcut reviews, but doing a full high quality review, but using automated tools to do it in a much shorter time. So we'd been working with multiple groups around the world on this for about 5 years when we decided in 2019 to try and do our first 2-week systematic review. And we published about this in the Journal of Clinical Epidemiology on describing the processes of it. And I first of all need to emphasize that there are actually 2 components. One is the automation tools that you see on the right, and I'll talk a little bit more about the components of those. But the second is a change in the process. We couldn't have changed the process without having the automation tools, but equally important to the compressing it to 2 weeks was having this streamlined process that included, for example, a team of 4 to 5 experienced multidisciplinary group of the appropriate clinicians, librarians, and epidemiologists scheduling this protected time in the 2 weeks. You don't need all the time off, by the way, but for some people they'll have to have the majority of time off. Having brief daily meetings where we ask these 3 agile questions. What have you done? What problems have you had? And what are you going to do today? And a big saving in all of this process and compressing it into this shorter period is the mental reload time that you have when you keep coming back to that review problem. You keep seeing the same paper, but you almost need to reread it every time. Well, if you compress it into this much shorter time frame, it reduces that mental reload. So you need both the tools and the process. And this is a list of some of the tools that we used particularly for the that first 2-week systematic review. And I want to emphasize some of these tools we've been developing, but many of them have come from other people as well. For example, our search refiner was developed by the University of Queensland and a group at CSIRO here. And we have to thank Ian Marshall and Byron Wallace for both Robot Search and Robot Reviewer, and to Clive Adams for RevMan Replicant, which helps you write the results section of a review by taking what's in the forest plot, etc., and then generating text from that. It was a brilliant idea of Clive Adams's from the schizophrenia group. And we're extending this range of tools and also trying to improve each one of these tools as well. So just to say where we've gone from here, that first 2-week systematic review, as I said, took 4 people. We had about 1,300 studies to look at and ended up including 8, and it took 8.5 work days. But since then, we've conducted over 20. This is a range of the first 10 of them we'd done, which vary in size in the number of titles and abstracts screened from just under 500 to over 5,000. Number of included studies has varied from 5 to 81. It's been a range of types, mostly randomized trials, but some observational studies as well. And the number of people has ranged from 4 to 14, and the number of work days from 5 to 18. And so you can see the one with a large number of people and the large number of included studies was the one that took 18 calendar working days. By the way, some of these are done over a longer period where you're only focusing on this a day a week, but actually we find it's better to try and compress it into a fairly short period, not necessarily 2 calendar weeks, but a fairly, maybe doing it all within a month. So just wanted to mention one new tool just because I find this one so much fun to use. This is our latest tool, which is the methods wizard for writing systematic review protocols. And with this, you answer a series of short answer questions, filling in just the word or phrases that you need, like the population, the interventions, comparators, etc. There's a drop-down menu for what databases you're going to search. It knows the people, so you can say allocate people to various tasks, etc. And everything is short answer. So we use this in a meeting that usually takes somewhere between 1 and 2 hours to develop the protocol, but we're focused on answering the questions, not on writing sentences. And that makes it much more focused and much more fun to do. And then at the end, we press the button and it generates the text that you see in that bottom right hand corner, because it's using canned text or actually several variants of that, because it randomly chooses from the structures to generate this draft protocol. And I emphasize draft because it's just a start, but it's great to walk out of that first meeting with a draft protocol already written for you without having to worry about the crafting of any sentences, and it's Prisma compliant because of the way that we've structured the Methods Wizard tool. So what more is needed? There's been a lot of progress, obviously, to get where we are, but there's still huge amounts of work that we still need to do. For example, we need to reduce the learning curve for the current tool set that we have. Each of these takes a little while to learn how to use and how they work together. So we have to train people before they come to it, whereas no one has to be trained how to use Amazons, for example. So we need an easier interface. We need to integrate that project management component better, because that's a separate, at the moment, it's a sort of separate guiding set of tools and principles that we use for that, but it could be integrated in with a set of tools. We need to increase the range of the tools and other types of review that we could do, network meta-analysis, scoping reviews, etc. And of course, the world of the literature is changing. We need better linkage to study registries, preprint monitoring and extraction, etc. of tools, particularly as we move towards living reviews that can monitor all of these things, not just PubMed, but also all of the registries and preprints, etc. for things that are coming out. We also need a wider use of the tools, and we'd think of doing that. We've done this with some pilot sites, but we'd like to increase the number of pilot sites and education to do this so that it gradually does become the norm in more institutions. However, to do all of this and to continue this development is also going to require funder support and development and a requirement by funders that you have to have systematic reviews done to justify new systematic reviews. So I've been talking about it for justifying, but I just wanted to also mention, just to close, is that systematic reviews could also help to improve the methods used as well. So for example, it depresses me to look at risk of bias plots like this where they're in calendar order, and what you see is they should all be moving towards greener, and that's not necessarily true. Why isn't it that later trials should have built on what had been used in terms of methods of the earlier trials? And if you did a systematic review that wasn't just looking at it for justification, but also looking to borrow and build on the methods from previous trials, we should have an improvement and greater degrees of green over time. And an interesting survey of methodologists from European institutions, some 76 statisticians, methodologists, etc., found, again, the cup is half full here for asking questions about whether they'd use systematic reviews in trial design. The median was 0.44, from 0 never to 1 always, so that half full thing. 67% had used a meta-analysis to determine some other parameters in the sample size calculation, such as standard deviations and baseline risks. 58% considered meta-analysis in effect size or alternative effect size in the power calculations. Only 51% had used meta-analyses to determine the health outcomes. Looking at the range of health outcomes that had been used in previous trials for that question would seem to be an important thing that you could do to try and improve on the outcome measures that had been used previously. So again, glass half full, but another purpose in doing the systematic review that we need to do a better job of, not just the diamond at the bottom of the forest plot, but also looking at the risk of bias and the methods tables that we've extracted to see what we can borrow from those previous studies to build on them. So coming back to finish on Brian Nosek's changing a research culture diagram, I've been mostly talking about some of the infrastructure that's required, but also how to make it easier as well. But we'll also need different folk to help with making it normative, making it rewarding, and finally the funders and institutions may want to make it required, but we need to do all of these other things first before we can move to that mandatory level. And of course we have that infrastructure with the databases and systematic review methods, but we need to develop an understanding of the problems with the meta research, but also doing the development work on the automation tools and automation processes more generally to make it easier for people and to make it eventually become normative, rewarding and required. Thank you very much for your attention.
Well, thank you, Paul, for this fantastic presentation into the principles and challenges of evidence-based research. Before we take any questions now for Paul, we want to listen to our second speaker. And I'm delighted to introduce him. This is Dr. Joeri Tijdink. Joeri is an assistant professor in the philosophy department at the Faculty of Humanities and principal investigator at the Ethics, Law and Humanities Department of the Amsterdam University Medical Centers. His research focuses on research integrity and research culture, publication pressure, open science, the validity of clinical trials, mental health in academia, and assessment of research and researchers. He is also the author of the book Scholar on the Sofa, How to Survive in Academia. And like Paul, he draws on his extensive clinical experience as a practicing clinical psychiatrist and co-founder and chair of De Jonge Psychiater, a not-for-profit organization that discusses and promotes research in psychiatry. Joeri's talk today will explore the quality of clinical trials and its relations with research integrity. Over to you, Joeri.
Well, good morning, good afternoon, good night, good evening, whenever you are in the world. Welcome from my side as well. I'm very happy to be here to be invited to talk on this specific special conference, the Evidence-Based Research Conference. It is a recorded session, so bear with me. I hope I still can communicate and contact with you. My name is Joeri Tijdink. I'm from the Netherlands. I'm from Amsterdam. I am a researcher in the field of research integrity or meta-research, and I'm also a psychiatrist. And today I'm not going to talk about any psychiatry, well, not so much, but I'm really going to talk about the quality of clinical trials and its relation to research integrity. And of course, we have seen our first speaker. Well, I didn't see him, but you have seen him, and he's it's an honor to be together with him on this online stage. And it's also a great collaborator, and I really hope, I know that he's surfing every morning, Paul. So I hope you had a wonderful surf this morning as well. And I'm really looking forward to see your talk as well. Well, I didn't see it, but in the future. Let's make RCTs great again. That's the main message of my talk, and I'm going to share my screen now. There you go. I think you can see it now quite well. Let me also, I really hope, yes, I think now we're all set. So this is the talk, this is me, and this is today on this conference. On the menu today, we start with RCTs as the backbone of evidence-based management. I'm going to explain it to you. Then I'm going to present some of our work that we did with my great collaborators on studying the published randomized controlled trials. We look at the risk of bias, we look at statistical power, registration of clinical trials, spin of research results. And after I've presented it, and I can already give some highlights that the quality of RCTs is not that well, and I'm going to give some ideas about how we can improve RCT quality, and also how we can foster responsible conduct of research, and how we can make academia great again. Well, some ideas about it. Not, I cannot, unfortunately, I cannot cover everything, and it's impossible to make everything perfect. That's also something that I have to say. So why in the field of research, we study validity of trial, validity of research, or the trustworthiness of research. And you have to start with, what is research exactly? And I think this is a good example why we make unintentionally, most of the time, mistakes in research, because it is a long and winding road towards the end product, and that's a publication. So it starts with an idea, then you have the design, you need funding, you need approval, ethics approval, you start the experiment, you collect the data, you analyze, you do another analysis, then you start writing. And this is most of the time, this is work that PhD students do and will be supervised by more senior staff. You start writing. You think this is the best paper ever. That's what I thought of my first paper. Best paper ever. I write it, I send it to my co-authors. Well, my co-authors definitely didn't agree that it was the best paper ever. So I asked them for advice. I completely rewrote. You have to rewrite your paper. Then you submit it and you think, well, this is so good. I should submit it at Nature. Well, Nature is not too open about their open science policies. However, Nature, of course, desk rejection directly, and you think, well, why is that? So you start submitting it other journals, and you think that the impact factor is very important. So you follow the impact factor, the higher the better. Well, you get rejected and rejected and rejected, and you think, what's wrong with my baby? Nothing is wrong with you, baby. There's just a lot of competition. So hopefully you end up in a peer review process after the editorial decision. You start revising your paper. And hopefully if you can pass the second reviewer two is always the harshest, the most harsh. So then you have this final publication, and then yes, you're there. This is this satisfaction. This is all why you're doing fine. I still can know exactly where I was when I received my first acceptance of a publication, and I was really happy. So this is the long road. So in RCTs, it's even more complex. There's so many steps, and it takes years before you can finally publish the results of RCT. But RCT are the backbone of evidence nowadays of evidence-based medicine. It is crucial for guideline development, for clinical patient care, for everything what you want to do, specifically in clinical work. You need to have RCTs in order to get your treatment accepted in guidelines and in daily routine care. So we know what is exactly evidence-based practice. It's not only on the research evidence, but it's also about clinical experience of the doctor or the nurse or a patient perspective. It's also very important. But in all these guidelines, all these treatment decisions, we focus on the research evidence and not so much about patient preferences or clinical experience. And I think that's highly undervalued in current patient care. And I'm happy to also be a psychiatrist, so I know also in my work with my patients that it can be very complex to make decisions about. Good informed shared decision making is crucial, and it's sometimes very complex to make good decisions in there and to convince, for example, patients if that's needed, specifically in psychiatry, which, well, on the side note, which is also the beauty of psychiatry, of course. So RCTs are the gold standard. The question then is, are these outcomes valid and trustworthy? So let's dive into some evidence that we have collected in the past years with my team. What about RCTs? So we first look, we included almost 200,000 clinical trials. We extracted the PDS, and we looked at the methodological rigor to understand that that's necessary to understand the quality of the evidence we use in our clinical practice. And if you see here, and this is the timeline, what you see that the number of trials have increased a lot. The numbers of authors also increased a lot in the past decades. More countries and more institutions involved. This means that RCTs are becoming more international and more international endeavor, also to include more patients. And what we see in these trials, we looked at risk of bias. And risk of bias is crucial for investigating or assessing the methodological rigor. And this helps us to understand the evidence. So it's divided, the risk of bias scores, it's in percentages, the risk that's actually bias in these trials, and can be flaws in the design, in the conduct of research, in the analysis, or in the reporting of randomized trials. And this, of course, can cause that the effect of the intervention will be underestimated or overestimated. And these scores can be automated by machine learning techniques. And what we see here, and then we look at the time again, is that we have 4 major groups of risk of bias scores. That you have the allocation bias, the randomization bias, blinding of people bias, and the blinding of outcome bias. And that you see here that over time, you see a gradual improvement of clinical trial quality. And how do you see that? Well, the risk of bias scores were actually quite high. In the early 90s, you see higher than 60% in some categories, and you see that the reduction is taking place over the years. So we become better in actually the quality of clinical trials. We're not there yet, definitely not, but we are getting there. And you also see, well, interesting also to see, and this is the beauty about doing meta research and having such high data sets, that you can see a lot more. You see, for example, the percentages of female authors has improved over time as well. First of all, 20%, now we're at 40 or 45%. And that the registration of these trials is also increasing a lot. We will come back to that in a minute. So first of all, the first quality methodological rigor quality score was risk of bias. Now we go to the second one, statistical power. And statistical power is the probability of a hypothesis test of finding an effect, if there's an effect to be found. So this is also expressed in a probability, and we consider higher than 0.8. That's considered sufficiently powered studies. So this is also something that you can extract over 150,000 trials. We extracted the statistical power, and what you see here, and these are interesting findings, that you also see an improvement over time. However, and that's important to note, is that the power is over time has improved, but not much. So the sufficient, we measured with how many trials, the percentage of trials is sufficiently powered. And you see in the 90s, very low, it's almost 10% of these trials. And in 2010 onwards, you see over almost 16 to 80%. Interesting improvement. It's not big, because what's 16% of sufficiently powered trials? Well, we know, if you have done ever a clinical trial, you know how hard it is to include patients and to get informed consent. So it is logical. We chronically fail to include enough patients for trials, or for the intention that we had before the start of the study. Very interestingly here, what we see here is that you see this red part of the histogram, is that there is one category of clinical trials that performs better, that has a higher percentage of sufficiently powered trials, and that's the male first, female last author group. And we were thrilled by this finding, because it's so much higher than the other categories. So male or female or female have lower rates of statistical sufficiently powered studies than this male-female group. We can speculate about these findings, maybe something for the discussion later on. Then we go to the third one, and I briefly mentioned this already, and this is about registration. So we know that publication bias and outcome reporting bias have very detrimental effect on the validity of clinical trials. And therefore, the FDA, in the US, they require that you have to register your RCT at clinicaltrial.gov since 2001, and the ICMGA required this since 2005. And we studied them, so we included almost 150,000 clinical trials, and we checked over the years about whether we checked the PDFs of these trials, and we checked whether they were registered at clinicaltrials.gov or in any other repository where you have to register your trials. And what we see here is that the number of trials that are registered on clinicaltrials.gov was really bad in 2002, for example. Hardly anyone registered trials, and that you see a gradual increase of the number of clinical trials that are actually registered. Interesting. So we are slowly getting better at registering our clinical trials. We're definitely not there yet. In total we're at 60%. But we are really getting there. We also checked for all the trials that were registered on clinical trials, though, if there were any, what was the percentage of people that actually changed their primary outcomes during the study. And this is interesting to see, because you know, in the log of clinical trials, you can check whether the authors have changed the outcomes. And we see there, and you see that this beautifully here, is that these changes do occur more frequent in early 2000, but later they were reduced. So we also are getting better, and we also are not changing that much the primary outcomes of these studies. The fourth category that we would like to discuss today about clinical trial quality is something that we call SPIN. I'm also looking at the time because I still have plenty of things that I want to cover today. And luckily for me, there's no timekeeper because it's a recorded session. So hopefully I can keep your attention for the coming period. So the fourth one is SPIN. So SPIN of research results is something that happens a lot, SPIN practices switching the emphasis on specific results, and this misrepresents the results while unfavorable data are suppressed, or that we try to make it look like better than it actually is. So what we did, we explored the use of positive words in abstracts over time. This is published a couple of years ago. And we included more than 137,000 RCTs. And what we did, we checked for the occurrence of positive words and negative words in the abstracts of these RCTs. And well, interestingly, what we saw that the number of 25 most common negative words that remained more or less the same, a gradual increase, not much. But for the positive words, and then you can think of groundbreaking, phenomenal, novel, favorable, amazing, all these words, you see an increase over time, and that it's that they use these words more common. So what we do is that we make these abstracts more positive, or that we use more positive words in order to convince or sway the reviewers and the editors to accept our papers. That's one of our conclusion that we draw from these from this study. So this is not what I'm going to discuss today. So to summarize, we have a relatively high risk of bias. Clinical trials are mostly underpowered. We're still not reporting our trials before the start of the study, but we are getting better at it. We are overstating and exaggerating our results using all sorts of wording to convince reviewers and editors to get published. And we even do that for p-values that are even non-significant. But we see improvements in the past decade, which is great. Also by law enforcement, but also that we are focusing more on clinical trial quality in several measures. More studies are registered and fewer study outcomes have changed before the publication. And the third one is an interesting one. It looks like female-led authors may improve the methodological quality of the trials they're working in. So this is the first part of this talk, and we talked about the clinical trial quality. And I'm going to go with you together what we can do about it. And first of all, why is meta research important? And maybe I'm preaching for my own choir here, but I think it's extremely important, because if you want to know how good our trials are, then what reasons a trial isn't good, then you know how to improve it. So it's essential to have this knowledge to understand the evidence, but also to assess and to value the evidence that is created. And if we can improve the quality of research, then we can also improve our patient care. So it is like being drawing a diagnosis. It's like a doctor. You first need a diagnosis before you can start a treatment. And if you have to treat clinical trials, the quality of clinical trials, you first have to know what is going on. So research waste, well, I think Paul has touched upon this topic already. Extremely valuable and important work that they have done together with Ian Chalmers and colleagues, published in the Lancet in 2009. This very important series about, hey, what's going on? It's 2009. What's going on with these trials, and they draw conclusions that they think that research rates may be up to 85% of the total research that is actually published in clinical research, of course. And what do they say? Well, we do not ask the right questions in order to get the good treatments. We may not use the appropriate designs and the methods. We do not have access to full publications or to the data of these publications. And we have over 50% of the planned study outcomes are not reported. That's something that we showed, and that showed some improvement, or are not even published. So we have a lot of problems in clinical research. And luckily, and good for us, we can do something about it. So how can we improve RCT quality? First of all, we have to look at, this is the scientific method. So you first generate a hypothesis, then you design a study, you collect data, you analyze data, you interpret the data, and then you publish it and maybe conduct the next experiment. So what we see a lot, well, we're not going to talk about replication crisis today, whether there's a crisis or not. Well, lack of replication is an important factor. Low statistical power, well, we discovered this. Cherry picking is also something that's extremely common. A lot of that you change the hypothesis, for example, and then you say, hey, this is a positive outcome, and you cherry pick this positive outcome, or that you change the hypothesis and say, hey, this is the hypothesis that we actually came up with, while you only hypothesize this after the results are known, the so-called harking. So a lot of different problems in the scientific method, and luckily we can do something about it. And this is how how harking looks like. This is a king, like we all feel as researchers sometimes. Well, maybe the senior researchers, that you use your bow, and that your subordinate draws on the wall where you have actually shot, and say, well, you did a great job because you hit the bullseye all the time. This is how it looks like. And I think this is something that we can prevent easily. doing this, registered reports or the two-step publication process. So the classic process is that you plan a study, that you do a study, submit it to the journal. Sometimes you get accepted and you publish a paper. But the registered reports by Chambers is, well, he didn't invent it, but he made a lot of, he put this on as an important factor, how we can reduce research waste and how we can improve the quality. So what you do, you plan a study. That's the idea of registered reports. You plan a study, you submit it to a journal, you respond to reviewers' comments. So you do not do the study yet. So you only publish the introduction and methods actually. Then you get accepted, whatever results may be, because you don't know the results. Then you do the actual study and then you publish the paper. And that prevents a lot of problems that we just have discussed. And I think it's a beautiful way. It should be something that we really have to think of in improving clinical trials. So the other thing is, of course, open science. Open science is not only about open access publishing. Open science so much more. It's about open source. It's about open data. It's about open infrastructure, open peer review, for example, open evaluation, both of papers, but also of researchers themselves in evaluation and selection criteria, and open evaluation of funding proposals, something also very interesting and important that we can apply to with open science. So there are a lot of different things that open science can help us to make the research process more transparent and thus more trustworthy, more valid. Then what can we do more? And this is something specifically for clinical research. We briefly talked about p-values, but very briefly, I know, but this is something we are really focused on, the p-values. And of course they tell us something about probability, and we really are focusing on the 0.05. I'm not going to dive into the discussion whether 0.05 is good or bad. I really think that we should shift the focus not to this 0.05 or not to the p-value, but that we really should think about the clinical relevance and the effect size and the confidence intervals of researchers, because we have a lot of trouble, and that's what you see here, in interpreting the p-values in certain studies. And this is something important because it's not about the p-value or because that depends on so many factors. It's really about a clinical relevance. Is the difference that you find in the study relevant for your patient? That's the question that we should ask. And that's the question that researchers also should ask. So what do you need to foster all these measures? And that's something that is sometimes overlooked, I think, because you need dedicated, experienced researchers. You need time, a lot of time in order to conduct it properly. You need money, you need infrastructures, you need role models, and you need good supervision and good skills. You need these soft skills to convey the message and to convey the rigorous research towards your peers and towards your colleagues and towards PhD students. So this is something that we really need in order to actually improve clinical trial quality. But this is also the problem with researchers, and you see a lot of very tired researchers that have problems in conducting the experiments. And of course, this is an over-exaggeration with these images. But I would like to highlight this because this is something that is getting a problematic in academia, because we have this publish and perish culture, a lot of publication pressure. The career opportunities for early career researchers are not that to be honest, very bad. We have very old school HR, human resource management. We don't know well how to promote people and who should be promoted. Very long working hours, which are conveyed in unwritten rules that you have to be on the lab. We have an unhealthy work ethos. We work so hard, and we don't know exactly why. Well, if we work hard and that we get promoted or not. We focus on impact factors and not so much on the quality of the work. These power relations, specifically for PhD students that have dependencies on their supervisors, all these problems create a culture of that researchers are overburdened. There's so many demands for them, and we didn't even talk about education or any other managerial tasks that they have in their work. And that's what we also see in practice. And for doctors, it's even, well, not even worse because it's incomparable, but we also have our patient care, of course. So we also should focus on these softer factors. And I know I'm a psychiatrist, so bear with me that I value these things and I find them very important. We can do something on different levels. So we can look at individual levels, we can look at cultural or structural organizational factors that we can improve. Individual, you can think of mental health in academia. How can we foster mental health? It's something very important. And if you want to know more about this, please contact me. It's also about personality, about values, about effective training, about responsible supervision. It's also about cultural factors that we created a culture of publish or perish. While slow science, learn to speak up, support responsible supervision is crucial in order for early career researchers to develop as a researcher, actually to really get into the scientific method. And you have structural and organizational factors that you can influence, like improve the funding system to reduce dependency, reduce dependency on funding, because as researchers, at least here in the Netherlands, but also I know in other countries as well, we are completely dependent. We are addicted to research funding, and we should improve that. It should be a more healthy relationship that we should have with funders. I think we are with too many researchers, and there's a hyper competition for the slots in journals, in funding, but also in academia itself. Therefore, we need to improve the career perspective for early career research. Otherwise, we lose so much talent that will go to other disciplines or will go to other areas in society. Well, we are working really hard on different recognition and awards. Multidimensional, well, we could talk, that would be different, and I hope we cover this briefly also in this conference. Multidimensional assessment, as I said, power relations, that will be a culture to speak up for early career researchers that will reduce dependency. And leaderships programs and role models can also help, because what we also know from research that we did, that these role models are essential. You have for early career researchers, like the good examples, they teach you how to do good research or responsible research. And these factors are related to research integrity, and that's something that that we have to keep in mind, that these factors can influence the behavior of research and to foster responsible research practices, and that the more pressure, the more overburdened you are, the more mistakes you make also in research. Therefore, I really think that we should think of a different mindset, which is very difficult to create, I know, but I think that we always tend to think about that more research is needed. But that's also the conclusion of a lot of papers, unfortunately. But is it really needed? Do we really need so much research? In 2019, we had more than 2.5 million publications. Peer review is not the holy grail for good assessment of publications. There's so much competition. Peer reviewers are part of this system as well. They also experience this hyper competition. So I think that it's not more research that is needed, but better research is needed. Because why more research is needed if it might be that even 85% of this research is actually waste? I think we should first focus on better research, and if we can improve the quality, which is already happening, which is also the good news of today, then we can think of more research. So first better and maybe then more. So what are my take-home message for today? RCT quality is pivotal to further the impact and relevance of clinical trials. Measures are necessary to make progression and improve clinical trial quality. And I think that we can do a lot about it. We don't do enough. We should think about measures in order to improve this. Mental health is important to convey research integrity and researchers. I think that, and I really think that we need slow and responsible science. Not more research, but better research is needed, and we can do a lot about it. We are academia, and we can make academia great again. Amen. That's something I really think that we can do. So I would really like to thank you for your attention. It was an honor to talk about clinical trial quality today and what we can do about it. And I'm very happy to hear your thoughts and ideas about this. And I would also like to thank my collaborators. They are great, and it's a team effort doing this research. We do it really together. So thank you for that. And I'm very happy to answer some live questions.
Wow, a lot of thought, food for thought there from Joeri. And I could see some amazing questions coming through as well, and we'll come to those in a second. I just want to tell Joeri that I loved some of your thoughts, in particular, for example, pointing out the importance of meta research, very, very close to all our hearts. Promoting slow research, a term that I at least hadn't come across, and of course ties in very well with other sustainable initiatives in many different industries and areas. And then, of course, the conclusion that better research is needed, not necessarily more. And with this, let us start our Q&A. I would also invite Paul into our highlighting. Excellent. So nice to...
Hi, Clara. Hi, Joeri.
Hi, Paul. Good to see you.
Good to see you too, Joeri.
Great to be together, even though it's in cyberspace. But you know, this is the blessings of technology nowadays, that we are also connected, and this is indeed possible. So
I really liked your metaphor, Joeri, of meta research as a process of diagnosis of the problem. It made me think that we have a premature mortality amongst our research of at least 85%. It's a very unhealthy research population, and that we need to make a diagnosis of what's causing that problem, as well as doing studies of what the treatments might be, not assuming that we know the right treatment to fix those problems as well. So it's a very nice medical metaphor for the whole problem of the sick research culture that we have.
Thank you. Yeah, well, that's the handy of being a doctor as well, that you start to think of that you combine these two worlds, and then you think, well, maybe I just have another patient, and that's research, and let's try to make research better then as well. Well, it's not. Well, sometimes it's also a psychiatric patient, I must say.
Paul, you were instrumental in putting out that 85% figure back in 2009. Do you think the situation is still the same as it's, would you say it is slightly better? And if not, or not sufficiently improved, what would you say is the main or the key barrier that is holding us back? It comes back to this diagnosis here, I'm guessing.
So I think Doug Altman was lamenting the very slow improvement. There is improvement, and I think Joeri showed that in his meta research, that we're gradually seeing improvements. But remember that what Joeri was showing is just clinical trials. I think since we calculated that 85% figure, what we're now discovering is if you look at other areas outside clinical trials, it may be even worse. Right. So while some things are improving, as we delve more into the problem, we're discovering that in other areas like preclinical research, you may actually have worse problems than we have within clinical trials. So we're uncovering that. And I think the key thing is it may gradually improve over time, just like I showed with the IMRAD taking 50 years to implement. And if you want to sit around and wait for it to improve over a 50-year period, if you're very patient, that's fine. But if we wanted to speed that up, we have to take some active measures to diagnose and treat the problem to speed that up. And there is some hope. I'll give you one example. And Joeri sort of alluded to this when they made the reporting of results mandatory in the USA for the clinical trials reporting, but didn't really enforce it. There was, over the next couple of years, an improvement of about 10% in the results becoming available. Interestingly, not 10% more publications, but 10% more results that were available on clinicaltrials.gov. So there are examples of improvement, but it's a very slow process.
Yeah. Go ahead.
I do agree. And I would also like to stay optimistic here, because I think this landmark paper by Paul and others is crucial for the awareness that the patient needs insight, right, in his own disease. And if there's no insight, he does not know that he needs treatment. And I think this is something very important, that we have to spread this message. Because if I look in psychiatry, for example, well, psychiatry, there are definitely some improvements. We have a lot of other problems in research. But if you see there, and this is an interesting figure, like 20 years ago, we thought that the effect sizes were about 1 or 0.8. And we thought, well, these treatments are really good. But now, with the improvement of the quality of trials, the effect sizes are reduced, like to 0.3 or 0.4. And that what this shows us is that the quality of the trials becomes better. So the effect, which is logical, is less, is not so big anymore. And I think this is something that is a good development. But on the other hand, well, a lot of my medical colleagues, and we're even not talking about clinical research, because that's another, that's another very big problem, because they feed into clinical research eventually. But we really have to spread this message still because we're now preaching sometimes for our own choir, but we need to go to other fields as well, to talk to orthopedic surgeons, for example, because they still believe in the p-value, that the p-value is sacred, and they just chase the p-value, and they're happy when they have a p-value below 0.05, and that's it. So there's so much work to do in the other fields to get the patient actually become aware of his disease.
I think this notion of spreading, the word is a really key one. Not only to other researchers and other areas, as you're saying, but potentially also raising this issue to patients, which of course is always a double-edged sword, because on the one hand, you still want to recruit, patients for relevant trials, but on the other hand, you want them to be advocating also for good research, so that they can be certain that if they participate, it is for something that is really both necessary and relevant to end users. And would you want to comment on that, Paul, maybe?
I might let Joeri go first.
So, well, the patient is indeed crucial, but it's very hard to, well, on the one hand, it's hard to engage patients in research, because but on the other hand, they need to give informed consent in order to actually be part of a trial, and eventually be part of an RCT, or even in a greater perspective, be part of a meta-analysis or systematic review. However, It's a difficult question. I would say, of course, the awareness for patients is important. That they can make and they can really do something about it. For example, the big funding agencies that support cardiac research, they do have a very important vote in what are the patient perspectives and what does patient need. So addressing the right questions, which is one of the key elements in the Impulse Lancet paper. I think they have a great role in there because we cannot decide for them what is actually important and relevant. So you need those patient groups. On the other hand, I really think that we need to work on the funders because, as I said, briefly alluded to in my talk, I'm also addicted to funders' money because without that, I cannot do the research that I want and I think that is good for society. So funders have a crucial role, and they are not so much aware yet how addicted their patients. Well, just continue with the metaphor, how addicted we are as researchers. So they can demand more, and they have the tools. They are starting to get the tools in order to demand this research integrity from the research they fund. They're not doing it yet, and they need maybe more staff to monitor. But I think that's another crucial element.
Yeah. Just to echo that, in the 2014 Lancet series, we concluded that lots of groups have a role, including patients, publishers, researchers, etc. But the most crucial one were funders. So if you think of Joeri's analogy of we have a sick patient, the research system, and we need to diagnose and treat them, the group that has the resources to provide the tools for diagnosis and treatment are really the research funders. Mm-hmm. But it would mean that they have to turn away from trying to get all of the research done to doing something proactively about the 85% waste. In other words, they have to, in a sense, create a research healthcare system.
Yeah. And
then fund that.
Yeah, ties into one of the questions that we received. Saying great to see that there are pledges and recommendations, but are the funders open enough such that we can start monitoring whether funded proposals indeed had good systematic review as motivation?
So can I give you some hopeful examples from the UK's National Institutes of Health Research program? First of all, in terms of getting trials published, they have a 98% in their HTA program of trials being published. So they took proactive measures. They invested resources to make sure, and I could talk about all of the things that they put in place. Within the HTA program, they also insist on a systematic review before they'd commission a new trial. And if it's not done, they will commission the systematic review. Mm-hmm. So 100% of the trials that they do are actually based on having the systematic review in place. But it again means that the funder has to, first of all, check it, as you say, monitor that. But then if it's not done, to actually provide the funding to get that systematic review done if they believe it's an important enough question to do. So they're illustrations of the sorts of things funders could do. And I'll give you one more that the MRC in the UK was doing, is that they had a trials methodology panel. So Joeri, I was thinking how the registered reports in some ways has some similarity with grant funding, right? So you, in a sense, you say, here's my protocol, I'm going to get it peer reviewed, and if it's good enough quality and an important enough question, the peer reviewers will say that, and then it will get funded. So the two differences, though, are one is that it doesn't get openly registered somewhere necessarily. I mean, that's sort of starting to happen, but it doesn't. And the other is that the process is not designed to give feedback to improve the quality of the proposed research. No. But the MRC has a process in the UK where they have a methodology panel that looks at the trials first and provides that feedback before it goes on to the final funding decision. So it's changing the process of grant funding to be a little more like the good side of registered reports.
Yeah, and you can further develop this with financial incentives, right? From a funder that you have, like if you receive 2 million for a specific RCT, and you say, well, we have these quality criteria that you have to comply with. So we give you now 1 million, and you receive, if you match all the quality criteria, you get the other half of the money at the end of the project. And I think so, like, and then you can really incentivize open data, pre-registration, make everything as transparent as possible, because, and even open applications. I think these kind of steps can move a funder. The only problem right now, what I see, and maybe funders are listening as well, is that for the fund, there are no incentives for the funders themselves. So it should be internally motivated, that they find that they are truly interested in quality of their research they fund. And this is sometimes a longer process that they actually are aware of this, how important this is for the community. And I think, for example, one other solution that, well, we just wrote something about open applications, and this is an open processes for funders, that it is open for everyone. If you submit something, that your proposal is actually visible for everyone, or maybe should be a small delay in publishing the proposal. But this makes it it has a lot of advantages, because others can see what is funded. Others can also see what you have promised. So others can also ask, hey, this is money from society. Why did you promised all these kind of things? And it turned out that not much has been published. What's going on? What happened that it didn't work out? And I think this type of transparency can actually help in improving the quality, and also improving the reporting, and all these factors that we have discussed.
Exactly. I mean, you know, you've touched now or talked a lot about the funding area and their responsibility, but I wouldn't want to lose sight of the other participants in this ecosystem. For example, you know, publishers, as you're saying, editors. So what would you say is their role in this? There's, for example, a question: how can we motivate a higher number of journals to require dataset sharing and study pre-registration in order to publish with them? So what are the instruments that you would say would really help us improve, you know, even though that step comes very much at the end of research? But I think if researchers know about particular regulations and requirements for the publishing, say they will be definitely influenced by that as well.
So I think if you think about the phases of the research in that diagram that Joeri put up from our 2009 paper, of the questions, the design, is it ever reported, and so what's the quality of the reporting? Different groups have different roles here. So I agree, publishers I would see as having a key role for the quality of reporting, that they need to check that you've used the right reporting guideline. And we know from the Cochrane review on this that if somebody actually checks the checklist, then it's improved. But if you just ask for the submission of the checklist, it doesn't do much. So just asking for a consort statement and nobody actually ever looks at it doesn't really do that much. Another thing you could do is insist that if you're publishing it, you've actually got to have an open protocol as well, placed somewhere in a public repository. So that's the sort of reporting end of things that I think journals could do a much better job of. But if you go to things like the registration, for example, or having systematic reviews, etc., you're really moving up to the funder end. It's the funders who have to make sure, and even ethics committees as well. So research that's funded, they should insist that you've registered your studies. And I know in Australia, they ask you to do it, but nobody actually checks that you've registered it before they give you the funding. It must be a condition of funding that your study is registered. You don't get $1 or €1 or whatever currency you're working in until it's actually registered. Only the funders can do that for funded studies. But there's also a problem, what's called own account research, studies that people do out of their slush funds or other funds that they have that doesn't go through a funder. And they're probably the only group would be the ethics committees, because they'll have to get an ethics approval, and the ethics committees must insist that it's registered before they approve it ethically. So I think if you think of that chain of research, you have to think of different people playing different roles, and the funders, ethics committees early on, publishers for the good reporting practices and lack of spin later on.
But also this notion of the publish or perish culture that Joeri mentioned, I think this also plays a huge part in, you know, this drive for more and more and more research. Would you want to just add a bit more thought to that?
Yeah, it was making me think, Joeri, of Doug Altman said in his scandal of medical research piece in the BMJ in 1994, we need less research, better research, and more research for the right reasons. So absolutely agree with that. And I think there is a global movement to try and do something about that. And again, both funders and research institutions have to do something about this. First of all, the funders in their track record statements that they look at for grants need to focus on quality and open science processes, not the number of publications as the key metric. Because that then drives the institutions who are hiring those researchers to also move to similar metrics. And so again, the funders have a key role here. If institutions try and move to that, but the funders are still rewarding the high number of publications, you can't crack the problem.
No, this is something that we really need a more multidimensional recognition and rewards scheme for both funders, journals, and institutions about promotion and tenure criteria, for example. And you should take actually these research integrity elements, such as pre-registration, using open science, open data, into account when you are actually assessing researchers or research teams or departments, how well they comply with these kind of measures.
Yeah, as set out in the Hong Kong principles.
Yeah, it also makes me a little bit, exactly, the Hong Kong principles, published in PLOS Biology, if I remember correctly, in 2019. It also makes me a little sad that Doc told us this in 1994. We're about 30 years.
After decades of frustration.
Yeah. And now, and at that time, we only published maybe 200,000 papers a year. And even not even so much. And he already said it, and now we're publishing 2.5 million papers a year. So I mean, it also, so I'm just trying to cope with my sadness a little bit now. Go ahead, Clara.
Yeah, so it's amazing. Let's take a look maybe at the researchers then, who are actually doing all that lifting. There was a question for you, Joeri. What can researchers skip in order to have time for other more important things?
Well, what should they skip? Well, I think they should not skip anything. Well, maybe they should skip listening to supervisors that want them to submit in high impact factor journals, and think about what is reasonable and where do they want to publish, and make sure that it is a nice journal where you can publish your results as fast as possible, and then hopefully also get good feedback. So that's probably a major burden, because like I said in the beginning, that you try Nature, it's not reasonable, and they just want to have blue sky research. And of course, there are exceptions to the rule, but don't try it. I just go for a nice journal that's also good, without always focusing that much on this impact factor. I think that will save a lot of time. And that's the difficulty about slow science. Slow science is, I think, then you have more chance of good science. But it also means that we have the system of PhDs in the Netherlands, and you have to have 3 or 4 papers published when you can actually defend your thesis. So the more people still have this mindset, the more more is better, right? But I think less is more in this regard, and that we should really assess the quality. And besides, that's just from a mental health perspective for researchers. Don't work too hard. I mean, go surfing, go hiking, go do where you feel energized. I mean, that's so much more important, because then research stays fun. But if you only focus on research and on these publications and on your career, I mean, you really should focus on having fun. And that's why I ended up in meta research, of course, because it's so much fun to actually see what's going on in research and try to improve it. It also gives, well, at least me, it gives me a lot of satisfaction, because actually I feel, although it might be baby steps, I feel that I can do something about it. And that always feels gratifying, that you try to make academia just a little bit a better place.
So who would have thought that we would end up talking about surfing and fun in a session?
Yeah.
Let me just...
I did surf this morning.
Okay, that's a big relief.
Keeping you sane. Very good. We are ending, soon. So I just wanted to bring in Hans briefly. Is there any particular question that you would like to ask as a final question to our panelists, Hans?
Well, considering all the things you have discussed and the problems researchers are facing, for example, the time it takes just to publish any kind of report, RCT or qualitative study or whatever, what do you think, both of you, of the possibility that all the original studies are removed and we are substituting them with repositories where researchers are reporting in just the data and the information, and what we are reading in the journals and what we are discussing are systematic reviews, scoping reviews, any kind of synthesis of these repositories?
So, Hans, I think that's, I'm almost with you there. I think that the primary place of reporting should actually be in a registry. And you might want to reconfigure what's in the registry so that that's the complete report. So in a way, a model for this is the HTA in the UK, where you have this final report of all the details of your trial, this long, unreadable report. But everything a systematic reviewer would want is there. But in addition to that, they can also publish the shorter version of it somewhere else, because in a way that's the advertising. Here's my nice summary 6-page article about the trial, and I wouldn't want to inhibit that as well. But I think we should get used to the idea that you're right, that it's the repository, the registry should be the place of primary record of the results of the study, because that's a key bump at the moment, is the inhibition to getting results out because of the slow processes of journals. To give you one example, the recovery trial produced their results as a preprint. It wasn't published in paper for months. It wasn't published at all by the New England Journal for months later on, and didn't come out in the final version until 6 months later. In that time, the results had saved 600,000 lives. So if we'd insisted on waiting for the journal publication, 500,000 people would have died. That illustrates the importance of having the preprint full text results available somewhere that's the thing of record, and so it's flipping the publication model. I think that the journals really are advertising and marketing. Sorry, Clara. And that
no,
the
I'm fully with you there, because we see this in other areas such as clinical guidelines. That if you utilize the new technologies in order to capture the data that that the guidelines are founded on, you can then start presenting the results in many different ways, and through that also really democratize the research presentation and visualization and the understanding of it also through the different participants of this research ecosystem, including patients. So I'm absolutely with you there. Sorry, I was interrupting you. Yueri, you wanted to add something?
No, I just wanted to highlight that the COVID pandemic helped there a little bit, because that's where the preprints became more visible. And of course, the journals speed up their processes as well. But I mean, that's also made the policy for preprint so much easier. Also in the submission process, that you say, okay, this is the submission, but you can already publish the preprint where you can share the knowledge, you can tweet about it, everything else. So it should become a practice, and then it's already open and you can do a lot. So I'm totally there with you guys.
So thank you so much, everyone. I think this has been an incredible session and a wonderful start to our conference. Sorry for overrunning by a couple of minutes, but it was just too interesting to stop earlier. We will definitely follow up on all the questions that have been posted in the Q&A. We'll ask our panelists to please provide us with written answers to that, and then we'll post those on the website. We now have a break until the full hour. So enjoy, have food, have fun, as we've been told, and see you back later on. Thank you so much.
Thank you so much for the invitation.
Right.
Hello, everyone. I hope we hear each other good. And welcome to the first session of oral presentations at the third EBR conference. And my name is Tomislav Meštrović. I'm the chair of this session. And just to shortly introduce myself, I come from the University of Northern Croatia and also from the Department of Health Metric Sciences at the University of Washington in Seattle. And in my research within the context of the global burden of disease, the quality of evidence is crucial. And this is why I believe the evidence-based research is more important than ever. And for this session with me as a co-chair is Tina Poklepović-Peričić, and I will give her the opportunity to shortly introduce herself as well.
Hello, everyone. I believe we already met. Not to lose any more of your time, let's just start with the presentations of very interesting research that our young colleagues have done. Thank you, Sandra.
Thank you, Tina. And indeed, in this session, we have three very interesting speakers and talks. And during these pre-recorded talks, you can ask questions. And we encourage our speakers to address them during the session and later at the end. And we hope to have a fruitful discussion as well. So without any further ado, I would like to announce our first speaker, Yuanxi. He comes from Johns Hopkins Bloomberg School of Public Health. He also conducts relevant research at Cochrane and was previously involved in some research projects at Chinese Center for Disease Control and Prevention. And the title of his talk is Trends of Randomized Controlled Trials Citing Prior Systematic Reviews in the Past 15 Years, a meta-research study. So I'm happy to hear this talk, and we can start. Thank you.
Hello, everyone. My name is Yuanxi. I'm an associate professor at the Chinese Academy of Sciences. Now I'm presenting our study titled Trends of Randomized Trials Citing Prior Systematic Reviews in the Past 15 Years, a meta-research study. Why do RCTs need to cite systematic reviews? That's because systematic reviews can help RCTs in many ways. First, systematic reviews can help justify an RCT. For a given clinical question, a high-quality and up-to-date systematic review can suggest whether prior evidence is adequate. This ensures that the new RCT is necessary and not redundant. Second, systematic reviews can help inform the design of an RCT. For example, they can provide the parameters for estimating the sample size. They can also assess the quality of prior similar studies to suggest the best methods. Third, systematic reviews can help put the results of an RCT in context. They can be used to compare the results of the new RCT with prior similar RCTs and assess the impact of the new RCT on the overall evidence. Some prior studies suggest that the citation of systematic reviews in reports of RCTs is low, but they have some limitations. For example, they have a small sample size and are restricted to a certain clinical condition or intervention. In the past decades, many stakeholders have been working hard to improve the citation of systematic reviews in reports of RCTs. It is very important for us to know if those efforts have paid off. Unfortunately, no prior studies were designed to answer this question. So our study had three aims. First, to assess the trends of RCTs citing prior systematic reviews in a sample without restrictions on clinical condition or interventions. Second, to compare the citation of prior systematic reviews across clinical specialties. Third, to assess the factors associated with the citation of prior systematic reviews. This study uses Cochrane reviews published from inception to August 2021. We selected Cochrane reviews with at least one update. For example, to answer a question, 5 RCTs were published first, followed by the first version of a Cochrane review summarizing all those 5 RCTs. Thereafter, 5 new RCTs were published, followed by an update of the Cochrane review. We can see from this figure that there was no prior systematic reviews to cite for the first 5 RCTs, but these 5 new RCTs could cite the first version of this Cochrane review. We also considered the publication delay and added a 2-year grace period to make sure that the first version of the Cochrane review was eligible to cite when the manuscript of the new RCTs were under development. Thereafter, we included 4 RCTs and considered them eligible to cite the first version of the Cochrane review. The eligible RCTs were assessed for the citation of prior systematic reviews. If a Cochrane review has multiple versions, any version could be cited by eligible RCTs. Eligible RCTs could also cite non-Cochrane reviews. Non-Cochrane reviews were considered eligible if they met our predefined methodological prerequisites that they searched at least 2 bibliographic databases, reported any form of quality or risk bias assessment, and intended to include RCTs. Non-Cochrane reviews were expected to be clinically relevant, that they assessed similar health conditions and interventions to eligible RCTs. The choice of eligible RCTs citing Cochrane reviews, non-Cochrane reviews, and systematic reviews of either type were assessed by linear regression models. The citation of prior systematic reviews was compared across clinical specialties by a CMH test. The potential factors associated with the citation of prior systematic reviews were sample size more than 100 or less than 100, single or multiple recruiting centers, different sources of funding, such as industry, non-industry, no funding, or not reported, authors from developed or developing countries, and the requirements of journals, such as explicit requirement referring to the consult statement, or no requirement of the citation of prior systematic reviews. Here are the results. We have screened almost 9,000 Cochrane reviews and included 4,003 eligible RCTs from 737 Cochrane reviews. Among the 4,003 eligible RCTs, about 31% cited Cochrane reviews, 42% cited non-Cochrane reviews, and 57% cited systematic reviews of either type. Most eligible RCTs recruited more than 100 participants. Recruited participants from a single center, were conducted by authors from developed countries, refer to the consult statement, and were funded by non-industry. This figure shows the trends of eligible RCTs citing systematic reviews. The percentage of eligible RCTs citing Cochrane reviews has increased from about 15% before 2008 to 41% after 2020. The percentage of eligible RCTs citing non-Cochrane reviews has increased from 25% before 2008 to 64% after 2020. And the percentage of eligible RCTs citing systematic reviews of either type has increased from 35% before 2008 to 72% after 2020. This table shows that the citation of prior systematic reviews varies a lot across clinical specialties. The percentage of eligible RCTs citing Cochrane reviews was about 42% in psychiatry, while only 9% in dermatology. The percentage of eligible RCTs citing non-Cochrane reviews was 56% in orthopedics, while only 15% in ophthalmology. The percentage of eligible RCTs citing systematic reviews of either type was about 70% in psychiatry, while only 26% in ophthalmology. This table shows that 3 factors were significantly associated with the citation of prior systematic reviews. Eligible RCTs with more than 100 participants are 1.15 times more likely to cite prior systematic reviews than those with less than 100 participants. Eligible RCTs with non-industry founders are 1.43 times more likely to cite prior systematic reviews than those with industry founders. Eligible RCTs with authors from developed countries are 1.1 times more likely to cite prior systematic reviews than those with authors from developing countries. This study has 3 limitations. First, we are not sure how much the cohort of RCTs from Cochrane reviews can represent all the RCTs. Second, we used the Web of Science to screen the references of eligible RCTs for non-Cochrane reviews. So we may have missed some non-Cochrane reviews that are not indexed in the Web of Science. Third, we used keywords to search for non-Cochrane reviews, so we may have missed some non-Cochrane reviews without keywords in their title or abstract. We have 4 conclusions from this study. First, the citation of prior systematic reviews in reports of RCTs has improved over time. Second, the citation of Cochrane reviews was significantly lower than non-Cochrane reviews, especially in recent years. Third, RCTs with larger sample size, non-industry funding, and authors from developed countries were more likely to cite prior systematic reviews. Fourth, about 40% of reports of RCTs fail to cite prior systematic reviews. In some clinical specialties, this number falls to only a quarter. Evidence-based research should be further promoted. I'd like to thank our colleagues for their hard work. This study is an international collaboration among researchers from China, United States, and Norway. If you have questions, please email me and I'll be happy to address them. Thank you.
Thank you for the very interesting talk. We already see some questions coming to the chat box. Tina, what's your suggestion? Should we leave the panelists to answer it in the chat box, or should we leave a discussion until the end?
We'll keep the discussion live. So if you can go through the questions, that would be great. Hello, yeah.
Okay, perfect. So there is one important question. Whether the saturation with available systematic reviews across examined medical fields is similar, and to elaborate whether low level of citing in certain field may also be related to the availability of systematic reviews for a certain question.
Hello, hi, can you hear me?
Yes.
Okay, this is a very good question. And based on the design, we made sure that each RCT has at least one Cochrane review to cite. So, ideally, all of them can cite a system Cochrane review. But for the non-Cochrane reviews, I think it's possible that in some clinical specialties, there might be more systematic review to cite. That is possible. And also like 10 years ago, like 20 years ago, the systematic reviews, the quality may be low. So like some reviews were not considered systematic reviews by our criteria. But now we can see like many good quality systematic reviews. So yeah, there should be like more reviews to cite. That is one reason to why the percentage has been increasing recently.
Okay, thank you. And do you maybe have some other explanations of such differences among clinical specialties?
Yeah, I think so. Yeah, there should be some kind of differences across specialties. Like I know in some specialties, like some researchers are not very interested in like evidence-based research. So I don't know, just a guess.
Okay, and there's one interesting question. So Cochrane reviews have the special section named Implications for Future Research. And what are your thoughts? Could that influence also the citability of these reviews?
Sorry, can you say the question again?
So there is in Cochrane reviews, you have a special section which is named Implications for Future Research. Can maybe that be the impetus to cite some of these reviews? And what is the comparison with non-Cochrane reviews in that regard?
Yeah, that's a very good question. Yeah, I think like the implications for future research suggest, what we need in the future, like what aspects of the question has not been addressed adequately and what should be done in the future. Yeah, I think if a Cochrane review has that section, yeah, the authors may be encouraged to set a systematic review because they have a very clear direction from the review. Yeah, that is possible.
Thank you. And how would you explain the difference between non-industry and industry-funded research in citing systematic reviews?
Yeah, we know the industry-funded research sometimes they don't follow the rules. For example, they don't report whatever is important by the guidelines, and they sometimes I don't know. Yeah, in the study, maybe if a study has industry funders, what they want is just to get some results from the study, and they don't care if my research is the quality or if my research is redundant. I don't think they maybe sometimes they don't care about this much. Maybe I don't know.
Okay, thanks a lot. It was a really interesting research and a great presentation. And I wish to thank you for opening this session. And Tina, yes?
I'm so sorry. There is just one question from Clara. Very interesting one. If you can answer that one, please. And congratulations for the wonderful work.
Yeah, I can see the question. Yeah, I think there are two reasons. The first one is the Cochrane reviews don't have like a systematic review or like meta-analysis in their titles. So like for some people who are not familiar with Cochrane reviews, when they search the reviews, they just type like systematic reviews or meta-analysis in the search box, but they may not get a lot of Cochrane reviews from the search results. For example, like using PubMed or Membase. And another reason is some Cochrane reviews are not, I think most of them are not free, right? And for some journal, we have some journals with open access, right? So maybe like for some researchers, maybe the Cochrane reviews are not that's available for them, like comparing to some open access journals.
Yeah, thank you. Great observations. And thank you once again for your presentation and interesting insight. And we will now proceed with our next presentation and speaker. It's Judith Schure, a consultant biostatistician at Amsterdam University Medical Center. She's also a board member and treasurer of the Netherlands Society for Statistics and Operations Research. And her interests lie in foundations of statistics and in applied work. So in that regard, she will give a talk entitled All-in Meta-Analysis, Furthering EBR with Simpler Statistics, Efficiency, Collaboration, and Communication. So I'm happy to hear the presentation from Dr. Judith.
It's great to be here. Really great that I can tell you a little bit about all-in meta-analysis, which is a new statistical approach to realize the goals of evidence-based research. And this is work that I did while at CWI in the Netherlands, which is the National Research Institute for Mathematics and Computer Science, in collaboration with my colleagues, Professor Peter Grunwald, Dr. Alexander Lee, and Maria Perez. So at the moment, I'm in a position at the Amsterdam University Medical Centers. So that puts me into a nice place to also put these ideas into clinical practice. And I'm seeing opportunities for that more and more. So all-in meta-analysis. To introduce this idea, I want to take you back to the early days of the COVID-19 pandemic, when we had no COVID-19 specific vaccines and existing studies, like early studies, were into repurposing existing treatments and vaccines. And one of those early trials in the Netherlands investigated the BCG vaccine, originally developed to protect against tuberculosis, to see whether it could also protect against COVID-19. And this started very early and also inspired many other trials around the world, such as this trial in Australia that was also quite early. And the reason I'm telling you this is that the Dutch BCG researchers were in close connection. They were in close collaboration with all their colleagues around the world. They had shared their protocol, such that many of these other trials were literally inspired by their study design and designed similar trials that could easily be analyzed together in a meta-analysis. Also, they realized that the data would come in slowly. You can vaccinate a large group of participants, but you got data as soon as you see the COVID infections occurring. And especially if lockdowns turn out to be very effective, the wait for the COVID infections for the actual data would be longer. Also, the data would be collected simultaneously around the world. And the statistician on the team, Henry van Werkhoven, saw a worry there. If all these trials are asking the same question, there is a multiple testing issue, that as soon as someone finds a beneficial effect, it poses a difficult decision to the other trials about whether they should continue their trial, whether that would be ethical if there's already a beneficial result. And if maybe at a later stage all those results would come out of all the trials put together in a meta-analysis, and in relation to the others, this first trial would show to be a fluke, an outlier, then it would be difficult to get all those trials back up again. So Henry van Werkhoven already realized this and already talked to all the colleagues around the world about this problem when we came in with the solution. And that solution was to do a meta-analysis that is all in, meaning anytime, live, and leading on interim data from the trials. And I'm putting live and leading in here because the meta-analysis itself can be the leading source of information for any decisions to start, stop, or expand trials. So evidence-based research. And this is what that looked like. We had a dashboard that showed live results. And this one is in demo mode. So this is actually synthetic data. But what we're looking at is a value for the evidence, an e-value for each trial, the yellow to red colors, and in blue, the meta-analysis. And this e-value is a notion of evidence. The larger it is, the larger the evidence in favor of beneficial effect of the vaccine. And as soon as it reaches 400, we can make a decision with a type 1 error guarantee at level alpha 1/400. So 1/400 is 0.2.5% alpha level. And that's the first benefit of this, its simplicity. This meta-evidence simply multiplies the study evidence. So all the evidence in the studies, the e-values, if you multiply them together, you get the blue line. Such that what you see is also the shape of the studies represented in the meta-analysis. For example, this dip, you see the trials contributing to that. Also, because this type 1 error guarantee is continuous for continuous monitoring, you can make all those decisions no matter how you like, and you can reach a conclusion early. So obviously all those trials independently observe much less data than the meta-analysis of all the trials together, such that the meta-analysis reaches this threshold much earlier, and you can conclude the research effort and make decisions based on that. And finally, because it's so simple, this accumulating evidence also allows you to prepare for a future conclusion. So this multiplication of e-values, I plotted it, the y-axis, on a logarithmic scale, such that you see the increase as a linear increase. And linear increases are easy to extrapolate, such that you can guess like how much more time or how many more events you need to reach a conclusion and can prepare for that, or advise trials based on this expectation of soon reaching the threshold. Live meta-analysis is also exciting. So if you are really in this collaboration while all the trials are ongoing, it makes a connection between the trials that also has many other benefits, such as advising each other on trial design. If a new trial comes in, you can discuss all the benefits and of the different designs. You can see what are the best inclusion criteria or definitions for the outcome to nicely fit in the other trials and to ensure homogeneity. You share protocols, make decisions based on design rather than results. For example, do the risk of bias assessment externally and completely unrelated to results. And the sharing of data. So this specific meta-analysis was an IPD, individual patient data meta-analysis, also allows for collaborative data cleaning, which makes it easier to find mistakes and also to do this well because you do it together. So the motivation to work on these statistics was actually already evidence-based research. So I knew about living systematic reviews and the research waste papers, and I saw an interesting challenge there in terms of statistical methodology to make all these intermediate decisions and to create a statistical approach that would still be valid. So even before the pandemic came, our work on e-values was already well suited to this in terms of testing, hypothesis testing as a way to make decisions, but also in terms of estimation, because there is a related approach called anytime valid confidence intervals that share these same characteristics. Also, these intervals, you can monitor them over time. You can make decisions based on them. So if you, for example, decide as a field that you need a 50% vaccine efficacy for this vaccine to be useful, then in this simulated data, you see the point where the 50% vaccine efficacy drops out of the interval. And you can also make a futility conclusion based on that with your anytime valid guarantees. So in presenting this approach, I don't only present the statistics. There's actually other categories of benefits that I usually mention. So statistics, efficiency, collaboration, and communication. The statistics is a really real step forward, because in a situation of continuous updating, which we would like to do also in living systematic reviews, it's actually quite difficult with other statistical approaches to retain type 1 error guarantees. And the other sequential methods that are out there are actually advised against by Cochrane, for example, to use them in living systematic reviews. Efficiency. There are other problems in the way we put statistics to practice. When we do a power analysis, we're actually calculating the probability of an all or nothing decision. And when a trial is not able to reach their target, their own recruitment target, we just call it underpowered, and we don't value it as much. Well, it's really only this idea of doing it with one study alone, one study and then an all or nothing decision, that makes a study underpowered. You could also see it as a brick building towards a building of evidence. Collaboration. Doing this on interim trial results is exciting, and it also allows for other improvements to the research process, such as preventing publication bias. If you're in this from the protocol phase, it's really weird that you file draw your results. And finally, communication. There's also a debate in statistics how to resolve, for example, the replicability crisis and how statistical methodology hurts science. And there's many different flavors of what statisticians like as interpretation of statistical results. E-values position themselves very nicely within that debate because they have more than one interpretation. You can think of them as likelihood ratios, and they're often very closely related to likelihood ratios. Fortunately, there's hardly any statistician that doesn't like likelihood ratios. They can be inverse p-values. If you like p smaller than alpha as an interpretation, you can just think of e larger than 1 over alpha as the same thing. You can think of them as base factors. If you like the Bayesian view, if you interpret an e-value as a base factor, you're also fine. And most of all, the one that I really like is they are betting scores. And that connects them to the accumulation of evidence. Betting scores in the sense that we also have investment portfolios, that money can grow under uncertain circumstances. These things also relate to how evidence accumulates in science, the way money can accumulate. And you can think of e-values as money in the same way. So the future of evidence-based research, is it all in? I hope so. I think it helps to answer these questions, like how to decide when would you not need more research. If you can agree on a threshold with your field, for example, if you can agree on 100 as a threshold with a 1% type 1 error rate, you can just use that threshold and compare your e-values to that threshold under any evidence-based research decision. So under any data-driven decision on doing more studies or less studies. While such study decisions actually introduce meta-optional stopping, introduce bias in conventional meta-analysis and in Bayesian approaches. Other question, how to design a new study in the light of existing evidence. If the existing evidence already gives 10 and you've decided on this threshold of 100, it's pretty easy that you need to design to reach another 10, because 10 multiplied by 10 makes 100. And you can take that as the approach. So no power analysis on your study alone, but really power analysis on reaching the conclusion of the field as a whole. Funders can ask for such power analysis to add what is already there, even look at registries, at protocols of ongoing trials, and see what are those trials aiming for in terms of p-values. And if you know that that's what they are doing, how large does your study need to be to add to that? And if you can get your hands on it, interim e-values are just as easy to handle as e-values of completed trials. So that brings me to the end. Here are some references. I would also really like to point you to my PhD thesis. That is really in the spirit of this betting approach to the interpretation of p-values. You can guess now where the all-in acronym comes from. It also has an introduction chapter that introduces evidence-based research and its connections to e-values and the interpretation of accumulating money as accumulating evidence in a way for non-statisticians. So with that, thank you very much.
Thank you, Judith, for the wonderful talk. We were all in your presentation. Really, really interesting. Already sparked interesting discussion. So one of the pertinent questions were, can you highlight in broad strokes main differences between this approach and cumulative meta-analysis?
Yes. So cumulative meta-analysis usually uses conventional statistics, meaning that they are recalculating a conventional confidence interval after each new trial is added to the meta-analysis. The problem with that is that those confidence intervals are actually not confidence intervals anymore. If you use a confidence interval because it has like a 95% guarantee, then if you recalculate it many times, it will lose out on that guarantee. And it might even be like only 50% of the true effects ever falling in such an interval in repeated use. So you lose the guarantees that are making you want to calculate an interval. So therefore, what we propose is to use the anytime valid version of confidence intervals in any cumulative meta-analysis. And that's more of a statistical change than any like philosophical or motivational change in the use of cumulative meta-analysis.
Okay, thank you. And before Cochrane reviews were done like this, if the findings were confirmed after 2 updates, then no more systematic review or studies were needed. But now with living evidence, do we have a different playing field? For example, do we know when to stop? Is there any threshold when enough is enough? What is your opinion?
I believe there should be. So I do know that there are fields in which they just want to study something more and more to get to know it better. But if you are thinking of patients and the question being, is a new treatment effective? And I would say at some point you have enough evidence, and it would be unethical to randomize anyone to control or randomize anyone to treatment if your evidence pointed towards fertility and there are adverse effects of your treatment. So I would say that in any situation where like going on forever and getting to know the phenomenon better is actually unethical toward patients, you should as a field agree on where your threshold lies, what's your threshold for fertility, what's your threshold for efficacy. And I would say use a threshold that also has type 1 error guarantees. And if you do so using e-values, you have a very easy measure to know how far towards that threshold you are.
Thank you. Great answer. And what you mentioned, collaborative data cleaning. Can you maybe elaborate on that?
So this is just anecdotal, but I've heard anecdotes like mine from other people doing like prospective IPD meta-analyses, that if you involve all the trials in the process, if you specify what you actually need, draw up like instructions to statisticians and local data cleaners, and email about things that you worry about, and come together and discuss how things are going, then you get into a spirit in which finding mistakes and tipping other trials to be aware of these things maybe cropping up into your data actually becomes a fun thing to do, instead of like this last step that you actually don't want to do towards writing up your manuscript.
Great, thank you. And you also mentioned a linear increase as a forecasting method for deciding how many more trials and evidence you still need. Do you plan to further research on that and maybe even empirically use it in the future?
Yeah, that's a good question, because the linear trend on log scale, it follows from the math. But you do assume that there is some sort of stationarity in the effects, that that there's like a minimum effect going on in all the trials contributing. And I do know there is some work about waning effects and even work on sort of change point detection in meta-analysis, where at some point maybe the standard of care has changed, and also your comparator and so your relative effect in compared to standard of care is actually something else. So there are good reasons to think that there are cases in which this linearity is something that you can't fully expect. But it is like a theoretical benchmark that you can use to look at graphs like the ones I showed.
Okay, thanks a lot. And there is a question also that it is interesting that citing of Cochrane reviews was significantly lower than of non-Cochrane reviews, particularly in recent years. Can you see the reason for that?
I think this is a question to the former speaker.
I'm sorry, then, okay. It just came to the chat, so I just read it, but I would like also to gauge something. What would you say is the main take-home message that COVID-19 pandemic taught us in regards to this live evidence?
Well, so we were collaborating with like 10 to 15 trials around the world, and the vast majority of them were willing to put the meta-analysis and the collaboration before their own publication. So I think the pandemic really re-asked that question to all researchers involved, like, are you in this to further science as soon as possible, or are you in this for your own publications? And I think re-asking that question to everyone also really triggered better answers than we've been giving to that question in the past, where at some point maybe also your entire research environment stopped asking the questions, are you in it for the science, or are you in your great quote by from Glasziou, are you making a cure, or are you making a career? And if everyone around you is making a career, nobody's really posing that question anymore, then you maybe stop thinking about yourself as well. And I think the pandemic reminded us to re-ask that question.
Thank you. Thanks so much. And thank you for this invigorating session. Some links were shared in the chat, but please, if you can share the link to your dissertation. It was a bit blurry during your presentation, so everybody can have an access to, whoever is interested, so it can take some keynotes from your work. Thanks a lot. And we will now start with the last speaker of this session, Stefan Schandelmaier. He's a research and methodologist from the University of Basel in Switzerland and McMaster University in Canada. And the title of his talk is a systematic survey suggested areas for improving methods guidance articles and led to the development of a new database. So I'm happy to hear the talk from Stefan.
Everybody, and welcome to our presentation, a systematic survey suggested areas for improving methods guidance and led to the development of a new database. I'm Stefan from the University of Basel in Switzerland. I'd like to start with those who perform a study and face many methodological decisions. For instance, how to search the literature, how to design a study, how to frame eligibility criteria, how to design interventions or describe usual care, sample size sampling, recruitment, randomization, lots of statistical considerations, but also non-statistical considerations such as saturation, how should I involve patients, how should I share the data, how should I implement my findings. For all these considerations, there are typically several, sometimes many methods to choose from. And the final decision is very important. If researchers make suboptimal or even inappropriate decisions, even for only a small number of methodological choices, the impact on the quality of research can be dramatic. Meta-researchers show again and again that methodological decision-making urgently needs to be improved. For instance, in this recent meta-study, the investigators identified 1,600 RCTs included in Cochrane reviews from 2020 and 2021. So this is most recent data, and looked at the methodological quality. Those are the results of their meta-study. The authors extracted the risk of bias ratings from this 1,600 trials. And as a reminder, you can see in the gray box on the left, the Cochrane risk of bias tool is a measure of methodological quality, focusing on randomization, deviations from interventions, missing outcome data, outcome measurement, and selection of results. They plotted the ratings in this table. Yellow means high risk of bias, green unclear risk of bias, and purple low risk of bias. You can clearly see that low risk of bias, or in other words, high quality evidence, applied only to a small number of studies, precisely 8%. All the other studies had serious or unclear limitations. Not all of the limitations have to do with poor methodological decisions. Sometimes limitations are just unavoidable, but most have. This leads us to the question, why are methodological decisions often not optimal? And here is a potential model. In the green circle, there is the research team, including those who are involved in methodological decisions. It's the investigators, it's statisticians and other methodologists, for instance, qualitative methodologists. It's ethics boards and funding agencies, and also journal editors and peer reviewers. Their methodological decision-making might be influenced by personal factors, including methodological training, attitude towards methods, awareness of the decision-making challenge. Their decision-making depends on the research environment they are working in, like the research culture and tradition in their field, time constraints, lack of funding, lack of statisticians and methodologists who are available for collaboration. And their decision-making also depends on methods guidance. Can I easily find methods guidance that supports me in my methodological decision-making? Is high-quality methods guidance available? How useful is the methods guidance for me? Can I understand it? Is it easy to follow? And this is a model of methodological decision-making, and this hasn't really been the subject of research yet. This means we could do a number of studies, for instance, in order to better understand personal factors and issues of a research environment, would have to, for instance, do online surveys of stakeholders involved or interview studies. What we did is we focused on methods guidance, and I will show in the following slides what we did. First, I'd like to show you a number of examples of methods guidance. Over the years, by looking at selected guidance articles, we observed a large variation, for instance, regarding the labels, abstract format, and development process. In this example, the authors labeled their guidance tutorial guidance. The abstract is unstructured and the development process is not reported. This one is also called guidance, has a structured abstract and a specific methods section that reports on the development process. This methods guidance has the character of a decision aid, has a brief and unstructured abstract, and the development process is not reported. In this example, the authors labeled it recommendations for reporting. This time the abstract is missing altogether and the development process is not reported. We wanted to know if the variation across guidance articles that we observed is generalizable to recent methods guidance. So we conducted a meta-study in which we systematically looked at recent methods guidance articles. Overall, we looked at 105 guidance articles published in 12 influential journals in 2020. And here's what we found. Regarding the type of guidance, 12% were reporting guidance and 88% were other guidance. By looking at 105 methods guidance articles, we identified 38 different expressions for guidance. Of those guidelines, only 38% had a mesh term expressing guidance and only 17% had author keywords for guidance. And only 42% of those guidelines had a structured abstract. 42% reported any development process of the guidance. 22% described the expertise of authors, and 54% reported clear conflicts of interest statements. A key conclusion from our study is that we have a serious issue of findability. It's currently very difficult, often just impossible, to perform sensitive and precise searches for methods guidance. Most of the guidance articles are currently not organized. Reporting guidelines, for instance, again, these are around 12% of methods guidance published, seem to be the only type of guidance documents that are systematically organized through the Equator network. The remaining guidelines, 88%, are hidden in Medline and cannot be easily identified. Another key conclusion was that we seem to have an issue of transparency. For the majority of guidance articles, the development process was completely unclear. We don't know how the authors developed their recommendations. All we have is to place trust that the authors are experts and know what they are doing. Most of the time, we don't know what the expertise of authors is. In addition, we found conflicts of interest statements to be mostly unclear. For instance, many authors stated that they had received funding from the industry. We were not able to judge, however, what the potential impact on the content of the guidance document could be. And finally, there's something that we did not investigate. We did not assess the quality or usefulness of the methods guidance. Those would be very important research questions for future research. To assess quality, we would first have to develop quality criteria. And to assess usefulness, we would have to ask the users. All right, this was the first part of the presentation. Now I'd like to show you a solution that we have developed for the findability issue. It's a new database called LIGHTS, Library of Guidance for Health Scientists. You can find it on the website lights.science. This is how the search interface looks like. On the top, you can search for a methodological challenge. On the left, you have specific search filters. And currently, the library includes 1,246 guidance articles. This is an example for using the library. I entered sample size calculation and used a filter to restrict the search to randomized controlled trials. This resulted in 12 guidance documents. I clicked on the first one, which is called Delta 2, and seems to be a rather important guidance paper. Those are the key features of LIGHTS. Our aim is to put all methods guidance article in one place. We offer methods-specific search filters. Website is open access. It's a peer-supported initiative, and we will do regular updates. It's a living database. If you like the idea, we would be very grateful if you help us. You can help us by disseminating LIGHTS on social media. You could include LIGHTS in toolboxes for researchers and mention it in lectures. You can also help us improve guidance by using it and provide feedback. For instance, if a guideline is lacking or wrongly indexed. And most importantly, we would be very grateful if you could share methods guidance that you think should be included and isn't already included with us by just sending us an email. Here's something that I'd like to mention. It's a project that's closely related to LIGHTS. In LIGHTS, what we do is we look at all the guidance articles and we index them with methodological terms, and we do that in duplicate. And why is that necessary? For instance, here are just two examples of methodological concepts. For instance, one is applicability, and you can see there are lots of alternative terms. For instance, generalizability, external validity, transferability, context suitability, transportability, transposability, directness, indirectness, all alternative terms, related terms, synonyms for applicability that otherwise one would have to consider in the search strategy. Or another example is subgroup analysis. Synonyms are subgroup effect, differential effect, interaction, moderation, predictive factor, heterogeneity of treatment effects. There is currently no collections for all those synonyms. So in parallel to indexing the guidance documents for LIGHTS, we are developing this taxonomy and thesaurus for health research methodology. We currently call it Theremy, and we hope we can publish that soon as an independent resource, for instance, for information specialists who are looking for alternative terms, information specialists who are conducting a systematic review of a methodological topic. Next steps in our initiatives are the following. We'd like to further develop the LIGHTS database. For instance, we would like to experiment with machine learning to identify methods, guidance that is eligible for LIGHTS. And as I mentioned, we'd like to publish the taxonomy we are developing. We'd like to create a registry for methods guidance that is under development. We'd like to conduct stakeholder surveys and interviews to better understand the personal factors, environmental factors that influence methodological decision making. We'd like to develop quality criteria for methods guidance. What is a good methods guidance? What is a useful methods guidance? And finally, once we better understand the situation, we'd like to develop guidance for developers of methods guidance. And this is my final slide with all my collaborators. Thank you very much to my collaborators. Thank you for listening, and we welcome any feedback to our research. Thank you very much.
Thank you, Stefan, for an interesting and illuminating talk, and we will definitely aid in sharing and your dissemination endeavors as well. So first, we don't have much time. I will just jump straight in the questions. We have two methodological ones. For example, could an EBR approach in the method section help the problem you're dealing with? And how had you identified the included papers?
Right, I'm not 100% sure. Hi, everybody. I'm not 100% sure what EBR in methods means, but I guess you're referring to the section in method line. Is that right, Hans?
Yeah.
Oh, okay. So if you have a methods guideline there,
we currently have no framework for how to develop methods guidance, but certainly reviewing the literature is an important step. We have a parallel project where we are working on developing such a framework, and the big question is, what should I review? How should I do that review? Because there's no guidance for methodological reviews. One important source is meta research, because there you can see all the practical problems. Another one is, for instance, simulation studies and empirical comparisons of methods. Another one is previous guidance. So certainly, yes, EBR will, it's not established as a concept, but it could easily be. What was again the second question?
What about conducting systematic review of method guidance?
Is that a question? Sorry.
Yeah, so what about conducting systematic review of method guidance?
Yes, yeah. If you want to inform a new guidance, you could first look at the previous guidance, and also all the meta research, and also other sources, and we're working that out at the moment. What are the other sources? Problem is, if you want to search for methods guidance, it's super difficult to find those. I guess that's the other question. So what we propose first, look at lights. Actually, it's based on manual searching the journals at the moment, like we did 30 years ago for other topics. So we go to BMJ. BMJ has a section, methods and reporting, and then we look at all those. Annals has a section of reporting and so on. Some papers, for instance, JCE has a series of all the great guidance. Trials has a series of TrialForge guidance. So we have a long list of all those sections, and we are actually screening them manually. There is a software called like website scraping that helps us to find them. And we are also working on a search strategy, like a search string for PubMed, but it's highly inefficient at the moment. So we probably have to work with machine learning to help us screen for methods guidance, and it's a research project on its own. Another question is how to share guidance. Just send me an email. We're working on a button where you can submit guidance, but just send me an email. Also, if you think guidance should not be shown because it's outdated, because there's a version 2 or something that's difficult for us to identify, let us know. If you're an expert in some of the fields, for instance, missing data, you can check light specifically for your area of expertise and let us know how the indexing works and whether guidance is missing.
Thanks.
Any other question?
Yeah, we have an interesting question. Are there common grounds for guidance documents you found, and could those be compiled? And who do you think is responsible for developing standardized guidance and to share it?
Common ground. No, there's high heterogeneity. Some are developed very systematically. There's one subgroup that stands out. It's the reporting guidelines. It's all the same. You do all the systematic survey of meta research. Then they do a Delphi, and then they develop a checklist. For all the other types of guidance, it's highly heterogeneous, and actually mostly freestyle. And the last question, I didn't understand who's responsible for developing guidance.
Yeah, the question is,
I guess it's
just
different.
Yeah, to gauge your opinion. Who do you think is responsible for developing standardized guidance and to share it?
Well, methodologists. I think that's what we do. We are complaining about the poor quality of research and more and more meta research, and we have to make sure we find a way to communicate with the people we're complaining about. So I think it's our responsibility to improve methods guidance, and whether we should standardize it or not, I'm not sure. I personally think it would help. If you look at the reporting guideline story, I think we should do that for other guidance too.
Thank you, and I think this is an excellent final thought for this session. Congratulations to all the lecturers, and any additional questions will be forwarded to you and then answered virtually. So thanks a lot We learned a lot. It was a really interesting session, and enjoy the rest of the conference. Thank you.
We have a lunch break now, so see you all at 1:30. Bye-bye.